Thank you so much. Mr. Director, any other items that you'd like to be able to? Okay, thank you so much. I appreciate your patience there. We are now going to be introducing Patricia Ryan. She's the Executive Director of County Behavioral Health Directors Association. Ms. Ryan, we're excited that you're here. Thank you so much for taking the time.
Thank you. This is sort of a daunting task to follow up on all of the testimony that we've had so far, but I think it's I applaud you for doing what you're doing, and I think it's the proper role of the legislature in providing oversight over programs that are funded by the state, whether they're run by counties or not. So I applaud you for that, and I want to tell you that I, along with Dr. Baylor, will assist you in any way I can to help you drill down and understand our system. So I just want to say that. Thank you for doing this. It's a very important issue. Our members also believe it's a very important issue, and they have been managing a very complex mental health system for quite a long time, since actually 1991 when the system was realigned to them, and then again in 2011 when Medi-Cal responsibilities were realigned. They are constantly experiencing change and having to adapt to different federal and state guidelines, which is just part of the job. But they believe, and they wouldn't be in these jobs unless they believed that the reason that they're there is to provide services to their community, and particularly they understand the importance of providing appropriate services to the foster care youth. Increasingly, trauma is recognized and has been recognized for years now, but we're getting more and more data and evidence to show what types of therapies are available and effective for children who've experienced trauma. So that's something that they're very much involved in trying to find evidence-based practices for and using as part of their psychosocial therapies. They definitely understand the vulnerabilities of the foster care population. And we have a myriad of psychosocial interventions, such as trauma-based cognitive behavioral treatment, functional family therapy, therapeutic behavioral services. We are in collaboration with the state on all of these things in implementing KDA services, a part of which is the CFT at the local level, CFT, right? Which we're very much supportive of. I personally, and I know our members, believe that that's the key. And we've been supporting in concept so far, because the details still have to be worked out. We've been supporting where we're going with AB 403, because all services are local. And I also participated in a meeting at DHCS this morning on how do we not only better serve foster care youth, but their parents. So if the kids are experiencing trauma, why are they experiencing trauma? It's because their parents have lots of issues, including mental health and substance use issues. So it's a big picture, and I've felt for a long time that county behavioral health and child welfare services and adult services should be working more closely together. I also feel that DSS and DHCS should be working more closely together. And I don't know if you know, but I actually retired and came back recently. So I skipped about 1.5 years since I was here last. And I was very pleasantly surprised to see the collaboration that's going on now between not only the two departments, but with all of us collectively on how better to serve foster care youth and how better to serve our communities, including the parents of the foster care youth. So I want you to know that we are very committed to this. We're working with, I'm probably over at Dr. Baylor's office 2 or 3 times a day, working on various initiatives that are very related. So we're working hard to improve services in a variety of ways. And we're committed to that, including the EPSDT performance outcome system, because the bottom line is when it comes to all the things that you and we all care about, it's about the outcomes. It's not about necessarily who did what when, although that's all important. what's really important is measuring whether or not we made a difference in these people's lives, and we really need to commit and focus to that, and I know that our association is committed to that endeavor. You already know that that counties are very involved in the JV 220 process. So any child who's in the foster care system, the court is involved in monitoring their medication and their prescriptions, and counties are very involved in having their psychiatrists oversee that process as well and review their medications. Our counties are also very enthusiastic about the new California guidelines for the use of psychotropic medication. We have talked about them quite a bit in our Children's System of Care Committee, and it isn't mandatory, you're right, it's not mandatory, but I will tell you that our Children's System of Care members and directors are very enthusiastic and are looking for ways to go and implement those back at home. Just a couple of other things, because I know we don't have a lot of time, but just I was looking at opportunities for, aside from all the work that we're doing together, which I think is critical, our members were very enthusiastic about a CMS report or guidance that they issued to states related to evidence-based trauma-informed care for foster care children. And we have reviewed those guidelines in detail at our Children's System of Care Committee, and our children's advocates at the local level are very enthusiastic about learning more about trauma-informed care, which of course, would hopefully lead to more psychosocial interventions and fewer needs for psychiatric medications. And finally, again, ongoing dialogue with all of us who are sitting at this table, and with the advocates and with the children and the parents, to really find ways to constantly improve our system for appropriate trauma-informed, resiliency-based care. And I want to echo what's already been said here about, I've heard for years about the inadequacy of our mental health system in California, and it's usually directed towards counties, and I'm not saying that counties, do everything right all the time. But I think one of the biggest issues that's been overlooked for many years is we really haven't had a non-specialty mental health system in California prior to January 1st of 2014, where the health plans were given by the state the responsibility for mild and moderate services. So prior to that, there really wasn't a system for kids who didn't meet the threshold of specialty mental health services, but they still came to county mental health because there wasn't a system to address their needs. So I think as we have this discussion, we really need to bring them in. We need to bring the health plans in. We need to bring the people at the Department of Healthcare Services in who are responsible for monitoring that level of care, because that's the vast majority of kids in our state. So we can't do it all ourselves at the county level. We have to develop a system where we communicate just like we have to communicate together. We need to communicate, all of us together, about what are the best things, what are the best treatments, how do we monitor those treatments, how do we communicate and collaborate with each other, what do our MOUs look like, are these people being served? Thank you.
No, I really appreciate it. Thank you so much, and I appreciate your time. I have 4 questions for you. One is, for as long as you've been doing this, would like to be able to get your perspective on the last 10 years. So why do you believe, and for those who you represent as well, have we seen such an increase in the use of psych meds within the foster youth system, particularly in group homes?
I don't know how to answer that.
Okay.
I don't know how to answer that.
Yeah.
Which is why, all of these different entities are looking at that. It could be because the proper psychosocial treatments haven't been available. I mean, I really think that we need to look at all the different reasons why that might be happening, but I couldn't tell you definitively why.
So the EQRO reports shows that there's been a decline in the mental health plans since 2010 for foster youth. So we've actually seen a decrease, while the budget has also increased over the last 3 years. So drivers of that, of having access to mental health services, can you talk about that? And And again, that's why I bring up it's not a one-size-fits-all approach. You have different levels of expectations depending on the county. Big fan of counties, right? And work very closely. So why have we seen that decrease, do you believe?
All I can tell you is I would like to see the data. I would like to see the data broken down. And I would like to really look at...
Have you seen the report?
I actually haven't.
Okay.
Is there a new...
We'll send it over.
Yeah.
Yeah.
I mean, I know the EQRO is
yeah.
available on the website, but
Yeah.
yeah. Yeah, I mean, I'm happy to talk to you about any of these things, to drill down, really get a perspective from the counties and answer any questions that you might have. I also would want to ask what's happened, what's happening in the overall mental health picture.
I mean, I think of the overall mental health
yeah.
picture, I think we could absolutely agree.
Yeah.
It has been underfunded for so many years, and whether it's urban or rural, it's one of our most pressing issues within our communities.
The other thing that I want to say, and Dr. Baylor talked about this a little bit
Please.
too, is when you look at the EQRO, they're measuring EPSDT. We have MHSA services now too, so some of these kids may be being served through that system. They may be being served in a variety of ways that weren't available prior to that. So I don't know the answer, but I think when we look at it, we need to have a comprehensive look and see what's happening.
For behavioral health directors, top 3 reforms that you believe are needed within the foster care system?
I would say the top reform is collaboration at the local level between the child welfare and the behavioral health departments.
Okay. Any other items that?
I think I've already mentioned it, but I think really taking a look at the mild to moderate and the health plans. How do they fit in? What's happening there? What can we do to improve that system so that there's a more comprehensive set of services available? Probably, I mean, behavioral health directors are no different than anybody else. If they know that their outcomes are going to be shared, and that they're going to be held accountable, and it's a good system of measurement, accountability. And, again, we're working with the department on putting together a good measurement system that will look at outcomes. And counties, one of the complaints that counties had about the former EQRO contractor, and also the current for a little while, is that they rely on the EQRO for data and for feedback, and we want to see our data. What are we doing? How are we doing? And if they don't get timely feedback, they rely on that for continuous quality improvement. So if you don't know what the data is showing, you can't fix it as quickly as you otherwise might be able to do. So timely data, we've had struggles for years, and Karen knows this, about our statewide data system. So counties have collected, especially regarding the MHSA, tons of data and have done their own outcomes systems, but they can't get data back in a way that makes any sense from the state because of the way they collect it. And it's not her fault. I mean, she used to be one of us. But you have to have a good data system. You have to have good medical records. All of these medical records, that's the third thing, electronic medical records that are interoperable so that we can actually see and track what's going on with the child.
Yeah, no, absolutely. And I appreciate that. And I think you're absolutely right in regards to, look, it's just human nature when you know that outcomes are going to be shared, right? You want to be able to drive home those services on the ground. I think you're absolutely right. And again, it's crazy that we're talking about the issue of medical records of not following, but it's just the basic that we need to be able to solve.
And I do think that Senator Hernandez's point is a good point because for whatever reason, behavioral health was left out of the federal incentive program, and this is the result of that, or one of the results. If you'd provided incentives to behavioral health systems, we would have had that in place probably by now.
Sure.
A lot of this stuff gets back to money, There are a lot of good things that we should be doing, that we would like to be doing, but you can't do everything, and everybody has different priorities. So what are their priorities, and who's going to pay for it?
No, absolutely. Thank you. I'm really glad you're here today.
Thank you.
And I really appreciate your candid comments as well.
Thank you. Thank you for inviting me.
We'd like to be able to go to our final panelist. It's Frank Mecca, Executive Director of the County Welfare Directors Association. It's good to see you, sir.
Cleanup, thank you.
Hey.
Frank Mecca with CWDA, and just in case you don't ask me what our members think are the top 3 reform areas, I'm going to answer it up front. Well, at least I'll give you one, and one is timely access to an adequate array of mental health treatment for kids in our system. And so we're very appreciative of the fact that you're having this hearing, that all the parties are at the table, talking about ways to improve services for kids in the child welfare system. Endeavors that preceded the psychotropic medications sort of issue coming once again to the fore, but certainly heightened and intensified in terms of interest and activity, and we think that that's a good thing. So for my members, our number one job is to help kids be placed in and thrive in permanent loving families, so that they can be safe and they can thrive as adults. And when kids in our system who've experienced trauma receive good mental health services and behavioral health services, they can overcome that trauma, they can bond with adults, they can trust again, and we can get really good outcomes. And when there are challenges in obtaining those services, it's harder to achieve the outcomes. It's harder for children to bond. You see more unstable placements, more frequent placement moves. It's sort of kind of goes without saying that for kids who've suffered types of unspeakable abuse that it's hard for us to sort of wrap our brains around, the trauma that they experience really requires a robust system of mental health. And we really appreciate all the activity and efforts of our partners in trying to deliver the best services possible. The child welfare system, we're one of the major placement agencies. The other is probation, who are not here today. But sort of our job is we're the parent of the child legally. We're responsible for the care and custody of youth that we take away from their parents, which is sort of an awesome power of government, if you think about it, to separate a child from their parents. So while we legally are the parent, in effect, we co-parent. We co-parent with providers, with children's attorneys. We co-parent with the courts. Let's remember the ultimate arbiter of whether a youth can have a psychotropic medication legally by California law is determined by the courts. So we broker those services for our youth. We advocate for youth as parents, as we all would for our own children. We partner with service providers like our very important partners in mental health and education, but we're not the direct services providers. And so our role sort of as a placement agency is often sort of adjutant, partner, but ultimately we take our responsibility as the parent of these youth very, very seriously. The challenges that many people have brought up in this hearing already, in some places and for some youth, and being able to get timely access to an adequate array of services, including psychosocial services, is frankly something that our members have experienced. And it's been an issue. It's been an issue we've discussed with our partners. We've talked about it some in the legislature, and everyone is pointing in the right direction. And I'm going to talk about some promising areas that we think you should continue to keep your focus on. But it has been challenging in some places, and for youth, with the adequacy of the networks, the ability to find specialty providers. As we've brought up the KDA settlement, the ability of our systems to retool quickly to comply with the settlement agreement of KDA, all of those efforts, sort of they've manifested themselves in certain ways. And I think the delays that sometimes that you've heard about is a reflection of the capacity issues and the ramp-up issues and the network sort of adequacy issues that that we have faced. I think there's a sort of two areas of focus and improvement systemically that I think are worthy of the committee's attention. The first is serving children in their home. Children historically in California and probably elsewhere have had to sort of fail up, has been the term used in the system. The access to early mental health treatment has not been a hallmark of our system. Children get access to services after the manifestation of mental illness has occurred as a result of their trauma. And one of the key aspects of the KDA settlement and AB 403, the continuum of care reform, is saying the services have to come to the youth where they are, and it has to be early, the E in EPSDT. And I think focusing on that for us as practitioners and for you as legislators who can support our activity is really key. The second issue I think that is really fundamentally important, and I know this sounds so obvious, but when systems work as a team on helping foster youth, all the research says the outcomes are better. So the efforts that we've put in place to have child and family teams collaborating on the case management of a youth, where it's not just the county placement agency, but it's mental health, it's caregivers, it's service providers. All the research says the kids' outcomes are better when that occurs. There's been a lot of voluntary activity in that regard for team-based decision-making that counties have been engaging in for the last 5 to 10 years. AB 403 turns it into a mandate, going back into a question that you've asked prior panelists. We think that that's appropriate. The idea that all children who come into foster care should be treated with and helped with a system that at its center place is child and family team-based decision-making. And I think that's really critical. So I know that the time is short. We really do believe that there's a lot of promise in the continuum of care reform with respect to mandatory early assessments, team-based approaches to caregiving, and having kids, if at all possible, and as a default, helped in families. Remember, it started as the congregate care reform. It was how do we make sure that children aren't unnecessarily placed in group homes and that those facilities are used as temporary treatment facilities. We think that's a key part of the solution to the problem, having kids served in families with an adequate network and supply of mental health and behavioral health services, pharmacological and non-pharmacological, and psychosocial. In order to get there, the activities that we're engaging in with respect to family teams is going to require support. We don't have enough families. This is the number two, for the question that you didn't ask me yet. Mental health services is a key issue, an adequate number of families in order to wrap services around. And the legislature and the governor made a start in providing counties some resources in the budget to recruit and retain more families, and relative caregivers are very important, but we have more work to do. The other thing that I would say lastly is in conducting our parental role, we need, as placement agencies and caregivers and kids' attorneys, I think we need, with respect to psychotropic medication and alternatives to psychotropic medication, two key supports. We need data. You've talked a lot about data in the Global Data Sharing Agreement. I'll point out that the bill that we're co-sponsoring with the National Center for Youth Law, SB 238, Senator Mitchell's bill, would essentially require that counties in the state enter into an agreement so that information can be shared, because that bill mandates that the counties receive matched data from the state's administrative Medi-Cal data, matched with child welfare data, to see which kids are on psychotropic medication, which children are receiving alternatives to psychotropic medication with an alert system that says, hey, this is an unusually high dosage. This is perhaps a polypharmacy issue where you should take an extra look. So the ability to have that data and share it with practitioners on the ground, I think, is critical. That bill would put that information before judges. So one of the things we've heard from the judiciary is, yeah, you ask us to say, is this psychotropic medication okay? But we need to see a fuller picture. If you want us to really be able to say that this is the best treatment course of action, I need to know more. And that bill, SB 238, is intended to and would provide even more information about what's gone on in a youth's treatment. And so that data sharing is critical. The other thing in the bill is training, and I think Mr. Lightbourne referenced it, and a couple of other witnesses referenced it as well. We're not medical professionals. I think you referenced it with respect to group home staff. SB 238 would provide for training for social workers, for caregivers, for group home staff, for the judiciary, and for others. So teams, families, data, and training, I think, are the key areas that we would like to partner with you on as we all point toward getting better outcomes for our kids in foster care.
No, thank you so much, sir.